Welcome back, everyone, from our last break. And for our last session here, what we wanted to do was really give you guys time and space to talk about what you want to. So really some time to get what you came here for. If there's a burning question that we haven't answered, if there's a topic we haven't gone over, now's the time. Bring it up, right? Get what you came for. And so to introduce the person who's going to be facilitating that conversation, we have our own Dr. Michelle Aebersold. She is a clinical professor at the University of Michigan School of Nursing and a clinical associate professor in the School of Information. She is a certified healthcare simulation educator and a fellow in the American Academy of Nursing. Dr. Aebersold is an XR faculty innovator in residence through the University of Michigan XR initiative. Dr. Aebersold has extensive experience in using a variety of simulation learning methods, including extended realities, to improve the care of patients through caregiver education and training. She is currently working on a grant-funded project using immersive virtual reality to improve the safety of chemotherapy administration and management of pediatric cardiac arrest situations. Dr. Aebersold has numerous publications. She presents on a variety of topics and is often an invited speaker at international, regional, and local conferences. She consults with nursing schools around improving their simulation programs, developing virtual educational assets, and other projects. In short, Dr. Aebersold is our expert on just about everything. So without further ado, we will let her get started.
Thank you. Took me a minute to get the right display up there.
That's okay. It took me a minute to get through your accomplishments, and that was the short list.
Oh, you didn't have to read all that. Well, first, let me just say it's exciting to be here, and I have appreciated hearing from many of my colleagues on different topics. So what I'm going to try to do is basically just take a couple minutes to sort of wrap up and just kind of review all the topics that you have learned over the past 3 days, address some things that I saw in the initial survey that may have been touched on, but I thought I would just add a few things, and then we'll open it up for questions. So we'll spend the bulk of the time on questions. So first thing is, let's go back. So just to kind of review sort of the key learning. So I went back through and looked at everything that we have talked about over the past 3 days. You've learned about the healthcare simulation standards, which, as you learned, have been sort of really updated and refreshed and are taking sort of a broader view and not looking at just nursing, but really looking at it from a healthcare perspective. You had a talk on mannequins, standardized patients, simulation design, psychological safety, which is super important. And then all of the work involved in facilitating pre-briefing and debriefing. And then the final talk today on basically hybrid learning, and a lot about sort of this whole area of telehealth and telesimulation and distance simulation. So many things involved in that. So what I wanted to just kind of go back and just revisit and just share a few things that I've learned throughout my years of working with people across, basically across the whole world, the globe, and looking at the whole idea of simulation in low resource settings. So one of the things that, in this actually, I was having a discussion with my husband today, who volunteers as a standardized patient in a local university. And so one of the things that we have actually done at the University of Michigan in the past, and I think would actually be really ideal, particularly in low resource settings, if you're not already doing this, is sort of leveraging volunteers from the community. And when I say that, I'm talking really sort of beyond using sort of the standardized patients or people to come in and be standardized patients, but actually consider using volunteers from the community to come in and be your simulator, so to speak. Instead of using a mannequin, put a person in the bed, put a person in the room. Not that you're necessarily going to be doing procedures on those folks, but if you don't have a high fidelity mannequin and you want the students though to practice certain things like doing an assessment, taking a blood pressure and things like that, reach out. Are there people around you who would come and volunteer some time, who you could offer to them? Maybe you can provide them, a small meal while they're there, or a health screening of sorts. If you're going to have the students do an assessment and listen to their lungs and things like that, then, that's information you can share back with them. So, just one of the things that I think is has been super successful for us, because we've used some of our alumni volunteers just to come in and let the students do, sort of a head-to-toe assessment on them and learn how to talk with them, things like that. Even just that whole conversation ability for our students to learn is really important. And then the other thing that I always try to do is, when you have limited money, how can you sort of maximize the mannequins that you want to purchase? So, you can take a infant-sized mannequin and, you can treat that for many ages. You can even use small dolls for students to practice bathing and holding and doing different things with. You don't have to have the high fidelity mannequin. You don't have to have the mannequin that has chest rise and fall, but can you purchase like some of the CPR trainers that some of the companies offer? You can do a lot with them. And it allows you to use some of the technology and then that you can afford, yet get multi-use out of that. And then the other thing that I found when I was doing a cohort of simulation educators over in the Middle East is people have invented some really cool stuff. There was a gentleman who essentially used a stethoscope that he sort of adapted by just using audio files like off of YouTube to simulate different kinds of heart sounds and breath sounds and all of that. So network with other people, reach out to people around you and say, hey, what have you developed? The Aebersold does have, and the National League for Nursing does have sort of simulation low resource settings, and they publish ideas and things like that that you can sort of pull from. The next thing I want to talk a little bit about was sort of faculty buy-in. So things that have been helpful to me, and I think to others, is when you're getting started, you'll probably find you can have people who are really interested and people who want nothing to do with this. So I always say, recruit the willing and the innovative and start small and create some small wins with those people. So when you, with the faculty and the folks that are really interested, get them involved early. It doesn't matter what class they're teaching, it doesn't matter what they're doing. Don't worry about trying to say, well, we need to start simulation, at the beginning. Find folks that are interested, do stuff with them. Word gets around. I know it does here. I'm sure it does everywhere. People hear about it and they want to know what's happening. Get the student ambassadors on board. Get them talking about it. If they're talking about this really cool thing that they did in simulation with other faculty that aren't involved, it may create some interest. One of the things that we did too was we sort of had like a little sim party, and this was when we opened our center, but we invited people from the community, alumni, different people in, and we kind of took them around and showed them how things work. So just get people down there to just sort of see what you're doing. The other thing is getting students involved in scenario design. There's been some interesting publications on that. Maybe you have a contest to see who can sort of design a scenario to meet certain learning objectives. And then again, use some community volunteers to come in and participate and do some of the things in your, and you don't even need a sim center to do this. You can just do, a classroom will work. So those were just kind of some pearls, and I wanted to just, and I'll probably stop screen sharing here just so that we can have a little bit better interaction and see faces and stuff. But what questions can I answer for you? And I will invite others that have presented or have interesting things to add stuff as well. Try to put up the chat window. So feel free to unmute, ask questions, put questions in the chat, and I will look for those. You know, maybe start off with, does anybody want to share a particular story about something sort of innovative or interesting that they did in simulation? So there's a question here that asks, should we summary with the ideal or expected performance at the end of the debrief? I think that's a great question. And I will tell you that some of the best experiences that I've had with some of our students is to, yes, sort of review how might someone go through and do that. You can go back into the simulation room or wherever you did the simulation and sort of walk through and show them maybe how you would do things. I do some simulations out in the community with emergency departments. I don't see a lot of pediatric patients. And so after the simulation, we actually go back through and kind of practice doing things like giving a flush or a bolus to a pediatric patient. I've also put up little videos of myself or other faculty kind of showing them how to go through and do an ideal simulation. I think the more we can role model for them, I think those are really great ideas. It shouldn't be a mystery at the end of the simulation what they should have done. This is all about learning and teaching.
Yep, I agree completely. And I believe the Anaxel standards do point to giving the expected performances at the end. And that can be a great way to point out something that maybe didn't go well without calling out a particular individual on their mistake.
Great. Other questions people have or other stories they want to share? Deb, I see you're on, and I know Melissa's on here somewhere. Do you guys have any additional thoughts you want to offer on that?
I could add, so one of the points, Michelle, that you talked about was using and leveraging volunteers in the community. And I can remember even from my graduate program, we did exactly that. So in my health assessment course, we actually went out to different school systems in our area and a little bit our area provided physicals and free sports physicals for middle school and high school students. And it was a great way to help them get their physicals because maybe they didn't have the means. They didn't have a physician that they could go to. And then it also helped us hone in on our assessment skills.
So that sounds to me a bit like actually clinical practice, which kind of brings up the point that there's not always an absolutely strict line between simulation and clinical practice. You know, I too did sports physicals during my training, but it was considered, I mean, it's real. It's not simulated. You know, the heart murmur you hear, the worrisome history that you get, how you handle that, you know, it's absolutely supervised clinical experience. So I think as some people brought up very early on, that there's skepticism out there about whether you can learn as well from a simulation as from real clinical experience. So I'd be sort of interested to hear, Michelle, what your answer is when you run into people who are like, well, but it's not the real world, and the students are going to be in the real world, so they need to practice in the real world. And the only thing we want to see is more hours in the real world. So how do you address those concerns?
So that's a great question, Megan. And I have a story that I share every time somebody asks me this question. And I ask them a question back and I say, well, let me ask you, would you want to fly in the plane with the pilot who practiced emergencies in the simulator or the pilot who's really never practiced at all? Because when we look at the airline industry, which has the highest rate of safety, those pilots learn how to fly a plane in a simulator before they ever fly a plane with people on it. And in fact, with some airplanes, the first time that pilot flies that particular airplane is with a plane full of people, and he has done all of his practice, or she has done all of their practice in that particular aircraft in a simulator. So we know from other industries that, particularly the aviation industry, which has been doing this way back in the days when they had developed the first link trainer simulation. So we know it works. So why wouldn't we take something that's successful, that involves human lives, that has some of the variability that we see in healthcare? Why would we not learn from them and practice in a simulator with our students, where they can make a mistake and we can work with them and help them make fewer mistakes or do a better job? And I'll also say that we're seeing the same results in the research in healthcare as well. We know simulation works. We have a lot of studies that say it works. We know simulation works for surgery. So the best surgeon that you want to go to if you want to have a laparoscopic procedure is the one who practiced it in a simulator and learned how to do it that way, as opposed to trial and error on people. So I think we just have to remind them that simulation works. The research is out there. It works for the aviation industry. It works for the surgeons, and it definitely works for nursing. Yeah, it was interesting. I shared that story about the airline industry when somebody had asked me a similar question, and we were just talking about, well, would you ever fail a student because they couldn't perform well in the simulation? And so we talked about that, and there was a time, and I think things have changed a little bit recently, but there was a time that pilots had to pass their test in the simulator in order for them to continue flying. I think, that probably isn't always the case, but if they don't do well in the simulator, they definitely have to remediate and practice until they actually can do what they need to do. So again, I think it's just a great way to remind people that this isn't just nursing, and it isn't just healthcare. Other industries use simulation to great degrees of success, including firefighting. They actually have firefighting simulators.
Michelle, this is Jody. I wonder
Jody?
if you could talk, or maybe Melissa and Deb as well. We allow clinical hours from our simulation lab counted toward our clinical hours. And that wasn't always true for licensure, right? Or for graduation from a nursing program. Were you involved at all in the change in that policy? And could you talk a little bit about what kind of strategies people could use to influence policy? I know some of the people online are in places where simulation is not allowed to be counted toward clinical hours, and they're very interested in having that changed. So I don't have any background on it, but maybe you do.
Yeah, so I can definitely speak to that, and would certainly invite Melissa and Deb to add thoughts as well. So one of the things that happened that sort of started that movement towards being able to count clinical hours towards simulation is the National Council of State Boards of Nursing funded a grant, and Pam Jeffries and Susie Carden-Egren were part of that work. And they literally did, sort of a high-level research study where they looked at students who had 50% replaced with simulation, 25%, and 0. And they were able to demonstrate that the students who had 50% of their clinical hours replaced with simulation did better than some of the other groups in some areas, or did just as well as the other groups. What they found was when those students went on into their first clinical jobs, they outperformed everybody. So the more simulation they had put them in a situation where they were better able to respond to changes in patient condition. They had less on-the-job stress. So I think one of the things is there is good research behind it. The other thing that happened at that time that this was going on, and I was actually on the board of directors for INAXL then, is we started putting out sort of position statements, statements that say, we as INAXL support the work in this study and support simulation being counted as clinical hours. The National League of Nursing did that. So many of the organizations that our state boards look at for guidance started putting the information out saying that they support this idea of replacement hours for simulation. For us in the US, and it might look different in your countries, although I suspect that it's similar, it really becomes an issue of governance and policy at either the state or region or country level. And that's where you have to really focus your efforts, is to change things so that the colleges are able to adopt the replacement, because from a legal perspective, they can do that. And I think probably there are folks from the National League of Nursing, from INAXL, from the American Nurses Association, who certainly would be willing to work with other countries who are looking, to try to move this forward in trying to get those simulation hours to count. Here in the US, we have different states have different policies. Some don't say anything, and so state colleges can do what they want. Some will say 25%, some will say 50%. Some will do 50% for specialty areas like mental health, where we have fewer ways for students to get access to that. So we do still have a variety here. Now we're really sort of focusing in the area of virtual simulation and trying to show that virtual simulation is as good as in-person mannequin-based. I think 50% is a good, so if I were going to start, I would probably start at least to try to do 25%. And again, you want to look at how many hours do your students get. So if the requirement is 100 hours, and you're able to easily get close to that in the clinical site, then maybe you look at 25% as a place to start. If the clinical hours are 100 and it's in a specialty area where you have really difficult time getting placements, or the students in those placements don't get to do much but observe, then I would go to 50%. I think that there are some places that have gone to 100% for things like pediatrics and that. You really have to sort of see what your access to clinical hours is and what your simulation center capabilities are in order to replace that. But I would say 25% is a good place to think about for most of what you do. Deb or Melissa, I don't know if you have anything else you want to add to that.
I do, actually. I know this is a hot debate in NOMF, which is the National Organization for Nurse Practitioner Faculty. And NOMF is definitely trying to get this changed for the graduate level. So we're in the United States, we're not allowed to use simulation for clinical hours for nurse practitioner students. And we are trying very hard, because my argument, and I think NOMF's argument, is I can do 100% of my clinical hours with patients and not see certain cases or certain diseases that are do not miss diagnoses, and critical to understand how to manage. And so, we're trying to make the argument that, there are certain things, malignant hypothermia is really important to recognize and treat, or postpartum hemorrhage. So we're hoping to get that changed at the graduate level. But the undergrads have been very successful at this, and Melissa, what are your thoughts?
I totally agree. And I guess going back to Michelle's information on the national study that was conducted looking at outcomes based on clinical and simulation, you kind of have to go back and think. So there are individuals with the mindset that they should be in the clinical, they need to see patients, they need to be in the real world. But we could have a student group in a clinical setting in any specialty area for an 8-hour shift. They may see very little, right? So there are different conditions, situations, and areas where they may not get any exposure to it. And the only exposure they get to it is through a simulated experience. And so that's why I think that the students who did have the portion of their clinical time in simulation were exposed and had to work through or use their knowledge and their skills in clinical situations that students who would just be in the real world may never have, you know, an opportunity to experience.
You know, and I think the other thing too, just listening to both of you sort of share your ideas and thoughts and work that you're doing, it reminds me of a story that I have used. Again, I like stories. I think stories sort of tell a lot, and using and leveraging those stories to help other people understand, I think can be really powerful. And we had a student who in her senior year, we do a simulation all around effective communication. And if you're caring for a patient and they start to deteriorate and you need to get somebody to listen to you, if you have to talk to, you know, the physician or the provider who may be not on site or not able to come and see the patient, you have to kind of paint that story in a few words and be very, very clear in how to communicate. So we have them practice that. So this student goes on to get a job in pediatrics, and she sent us this email to tell us the story. So of course she goes through orientation, and as many of our new nurses in our healthcare settings, they end up on the night shift, right, with fewer resources around. And so she talked about this child she was taking care of, and the child started to deteriorate and was having difficulty. I can't remember what, if they were having difficulty breathing, but there were some things going on. And of course, immediately she's, you know, like, oh my gosh, panic. And then she said in her email to us, that I remembered what I learned in the Sim Center. I remembered what you said to us. I remember what you told us to do. We gave them 3 simple things to follow: what I see, what I'm concerned about, what I want. And she wrote it down. She called the physician. She said that very thing to them. And sure enough, the physician came right over to see and address what the issues were. And she's like, I was so scared in simulation, and, you know, I was always nervous, and it wasn't really my favorite thing to do. But now looking back on that, I can honestly say that it was simulation and that experience that, you know, really made an impact on getting the child the help that they needed. So I think stories like that can help people, particularly those who may not understand a lot about simulation or a lot about nurse training, but they certainly understand if they themselves or a loved one are in the hospital and need help. So, you know, again, I would also, you know, in addition to the resources, and I put a link to the NCSBM study, I would also talk about, you know, any of those stories, start collecting those stories. So these are great questions. Other questions people have, other things that that you want to know more about?
I think there was a question so back to your idea about I can't remember. Yeah, I think it was you, about having a contest for the students to develop case scenarios. And it's intriguing also in terms of a way to engage clinical instructors, maybe by having a contest. Can you share more details about the contest?
Yeah. So I think there's a couple of ways that people sort of get this excitement around simulation. So one of the things that, and I don't know if this is still happening, I'll see it at some conferences. It's called Sim Wars. And basically it's a competition where teams practice simulation, you know, responding to patient deterioration simulation, and then they compete against each other to see who's the best. So it's kind of like a practice, you know, like you're a sports team practicing. And so when they do that, the students that are on these teams, or they also sometimes can be sim instructors or whoever's on the team, they have to create their own scenarios in order to practice, you know, crazy things that might get thrown at them in this final contest. So That's one of the things. Our flight team from Michigan Medicine actually went all the way to Prague and won. It was Medi at the time, but they had like the Medi Cup. So it was this like, you know, international simulation wars. The other thing with students is to make it you might want to think about making it a class assignment where you put the students in groups and you ask them, you give them a topic, say, I want you to create a simulation around respiratory. And then you have another group that might do a simulation around a patient with a mental health crisis. So you give them a topic and then I would give them a template like you've learned about, and then actually have them design the simulation, maybe do like a little pre-post quiz that goes along with it, and then have them maybe run faculty through it, or have them run, you know, the different groups can facilitate the simulations for each other. And, you know, you can create like, you know, maybe the faculty vote on sort of, you know, the most difficult or the most exciting, you know, whatever it is, create some categories. But really it's about sort of getting the students involved and making it fun. Give them points for doing it, you know, but don't grade it in a way that, you know, creates, or that sort of takes away from their ability to kind of have fun with it. And I think that's a great way to do that. All right, so I have another question in the chat. Just let me, okay, clinical hours, more about how INACS will be able to support Jamaica and that. So yes, Irene, if you reach out to me after, I will give you my contact information. I will be happy to share some resources with you or put you in contact with some folks. And that goes for everybody else too. You know, you have my contact information, reach out. If there's things that I can share with you, I'll be happy to do that. And if you do go on that National Council site, you may find some resources there. But we have for INACS, so we do have like an international group of folks that meet. And the other thing is, I'm just going to put a little plug in for INACSL as well, is for folks that might be interested in joining but are concerned about the cost. There is pricing depending on the country that you're from. So what we pay here in the US and Canada would look different depending on the region that you come from. Yes.
Hi, Isnar. I have a question in terms of when you use simulation with group works, like a group of 4 or group of 6 or 8. Do you grade them as a whole, or you do it individually, and how do you manage the time to do so effectively?
Those are great questions. So I will share what I have done in the past and then invite others who may have some other helpful tips to weigh in as well. So with the group simulations, I have always tried to run simulations where I will put 2, maybe 3 students in the room to actually do the simulation and then have others watch. If you get too many students in the room, then it gets confusing and it's harder to sort of see what the individual students are doing. Now, there's a way you can sort of, I'll call it a tag team approach. And that is, let's say you have a scenario and you've got it projected to run for maybe 45 minutes, which is a little bit longer time frame. What you can then do is, let's say you have a group of 6 students, put 2 students in for the first 15 minutes, the others have to watch, and then they do a handoff, and a very quick handoff. They're not getting a report or anything, but they're basically almost saying, okay, the next 2 students are up. So the next 2 students have to go in and pick up and continue on the care of the patient, and they do that for 15 minutes, and then you say switch, and then the last 2 students go in. That way, you have an opportunity to see how all of those students perform. You also have an opportunity to see how do they work together as a team? How do they help each other out? Nursing shouldn't be a solo profession where you're caring for your patient with nobody to help you. We should always have the ability to ask other people to help us, and that's sort of role models for students to do that. In terms of grading, I am very careful about how I award points for participating in simulation and even debriefing. And I'm not as interested in grading on how well they do as I'm interested in grading on what do they do, how do they look for help, how do they handle it if they do make a mistake, how do they sort of talk about, gosh, I was doing this and I see now that wasn't the right thing to do. Are they able to sort of reflect back and learn from that? To me, those are the students that you want to give all the points to. And other students who maybe hovered in the back and didn't try out new things, you know, they maybe get less points. So it's really more about how much did they participate and how much did they learn from any mistakes that they made. And I'm very clear with the students, this is all about learning. Now, there are times when you actually do have to grade them at the end because you need them to show you certain competencies, and that's okay. But always be very clear with the students how it is that they're earning points, if they have to pass this, what they need to do to pass it. There should be no secrets in that. So I don't know, other thoughts, Jessica, Deb, Melissa, anyone else?
Yeah, totally agree with what you said. And I think the biggest component there, based on our talk about psychological safety from Dr. Adams and what a lot of Enaxel talks about, is just no secrets. No, I think it's less important, honestly, which form or type or screen that you use, as long as your students have the expectation and it's clear to them what it is and how it works. If you're upfront with your students about those expectations, then I would say almost any form is going to work for you.
Yeah, I agree. I totally agree. Giving them the rubric a couple, a week or two in advance, so they know what they're being graded on, I think is really, really helpful to them. And it brings down their anxiety as well, so they can focus on what they need to learn.
Mm-hmm. I don't know how your students are internationally, but here in the United States, they are rubric focused. They like to know the exact point breakdown and exactly what's expected of them. And when they don't have that, they can derail very quickly. So providing that information can really help you out.
And just to add to that too, rubrics can include things like tried out something new. You know, doesn't always have to be everything focused on, I listened to the lungs and I did this and I did that. You can add a point in there for, I tried a new intervention. Again, just to encourage the students to try something that, or, I called the provider, or I enlisted help of someone else when I got stuck. So again, I think the point of students are really cued into that rubric is absolutely true. So just make sure that, your rubric encourages also the kinds of things that you want our students to do. And the things that support their learning. Once they graduate, they're on their own, and we want to try to help them learn habits to continue their learning. It's a great question. Any other questions people have? Sure, absolutely. I'd be happy to talk. I'm always talking about my virtual reality work. So
I do see a hand up though, if we want to
let's
address
do that.
first.
Absolutely. Yeah.
This is Miriam, and I'm asking this question from a law resource center, which does not control its budget. And the question that I posed was, where do you start in setting up a simulation center or just a simulation lab, because I felt like, yes, we had something, but because nobody knew what equipment needed to be done and what is the setup, we are imagining what a simulation center looks like, but we have no clue. So I think that is number one. The other thing is, if you can direct us to the maybe online courses that can at least jack us towards what does it take to, it might not give you a qualification, but at least it brings you up to the scale of being a you said that there is something called simulationist, but at least the basic skills of being, participating in a simulation lab to bring our students. Because I think from this discussion, which was very good and an eye-opener for me, was realizing that we have been doing task training basically most of the time and basic level task training, but we can up it to other skills and other levels of teaching. Thank you.
Great question. So let me talk first about the Sim Center. So that's always the challenging thing, is to figure out, well, what do you need in your Sim Center? I think people get the lab, they get the fact that, having some task trainers and things like that are important and are helpful. So one of the things I might start doing is to look at other centers. When we were building ours, one of the things that we did was we traveled and looked at some different simulation centers to see what did they do, how did they set it up. I would also make a list of some of the things that you might want to be able to do in your simulation center. So is doing, assessments on patients, whether they're volunteers or standardized patients, is that a big piece of what you're going to do? If that's the case, then you may need to set up a room where you have some privacy. If you really want to have sort of single patient, single mannequin sort of simulations, maybe you just set up a room where the students can go in and you have some medical equipment in there and you can do a simulation, and maybe you install one camera that you could, run a feed out to, either run a Zoom session and the students could log on and see what's happening, So first I would just kind of go around and see, what do other people have, and ask people that are like you, how did they go about sort of setting it up, and how did they get, some support or budget or things like that. You're going to learn from how others have navigated that. The second part or the second question that you had is about online learning. So one of the things that we'll share with you in your resources is access to an online training that was actually put together by Dr. Pam Jeffries. And it's in it's a MOOC, which is one of those massive online open courses. It's free. It is basically sort of, I'm going to say, simulation 101. So it's some of the topics we've talked about today. And it's something that you can go in, and it's all online, and you can sort of go through the different modules, and they'll cover a lot of this information. I would also encourage you to access some of the websites from places like INAXL, Society for Simulation Healthcare. Some of them will have nice little booklets or papers that you can download to talk about, sort of starting and setting up your Sim Center. It's a big task, but, reaching out to others who have done that in your area, I think is probably going to be the most helpful. So good question on inter-rater agreement from 2 instructors to give scores for students. So one of the things that I will say is, if you're going to score students, I would definitely use a standardized tool, and I would definitely do some rater training. And it may be that you have two independent instructors writing that and then sort of coming to agreement. If you're going to use the simulation and the scoring to make determinations around pass fail or student grades or things like that, then you want to put some rigor into that. And so I would definitely, whoever is grading them should have some training and some practice and some inter-rater reliability for sure.
I wonder if, I really like your suggestion, Michelle, to have them reach out to other centers that are similar to them and see what worked for them. And I wonder if we might take a minute here to maybe identify some of those centers. Are there folks from centers where you guys are kind of just starting out, really trying to build, maybe just started building your program, so that you can form kind of a supportive cohort amongst yourselves? And maybe it would be easier to identify that in the chat.
Yeah, I don't, not knowing where everyone's from,
Yeah.
and what, what they have access to, I would say, well, two thoughts. One, reach out to people around you and ask the question. And then two, if you're a member by NAXL and you haven't joined or been part of the international work group there, they have an international group, that might be a good place to maybe reach out to some of those folks who work in different areas.
Great suggestion, yeah.
And maybe even like I'm thinking PAHO and the WHO and stuff may have some information on their website for who might have a simulation center that they could reach out to. But I don't know of a list anywhere, unfortunately.
No, that would be too easy.
Yeah, that would be too easy, right? So I will take a minute before I know Jessica probably will, everybody wants to wrap up. And I'm just going to quickly share just one resource that we have that's actually available. And I will put the links in the chat and then we'll clearly send the links out. But one of the things that I have been working on, let's try this again. Hang on 1 second, I gotta close out my PowerPoint. But one of the things that we've been working on recently is some work around virtual resources. In particular, we're looking to develop things that can be easily used by others, no matter what kinds of technology you have. What are you guys seeing? I've sort of lost track here. Are you guys seeing something that says caring for military veterans?
We are, yes.
Okay. So one of the things that Dudley and I worked on recently is developing something called 360 video. And 360 video is essentially sort of an immersive video. So it allows the students to sort of feel like they're kind of right in the middle of what's going on. And all of these videos are hosted on YouTube, which makes it easy for students who maybe don't have a smartphone, maybe they have a tablet and you could use that on a tablet, or maybe the only thing they have is to computers at the school. But these are videos, and I'm just going to sort of pull one up here to sort of show you what they look like. They're essentially videos that you can
about to see
scroll around in. So as you see, I'm going to kind of drag the visual that you're seeing so you can kind of see what the environment looks like. And so, and here's our patient that you're going to meet. Just going to fast forward this a little bit. And so again, you're going to see just sort of the action that's happening, and the students can kind of scroll around and they can listen to what's going on.
Off and on for a few years.
Okay. And where's the knee pain at?
Just kind of on the inside of my knee.
Okay. And anything that makes it better?
There. These are available if you are interested in them. We have several that are caring for military veterans, which I would say it's not necessarily US centric. I mean, it really could apply to anybody who has been in any kind of military service, even police officers, things like that. But it also just has good fundamentals of patient care around how to talk to somebody who is experiencing a suicidal thoughts, or how to take care of a hospice patient by sitting down and taking time getting to know them. So there's a lot of interesting things in there. And we also have some that focus on caring for patients who are deaf or hard of hearing. But they're nice, short virtual scenarios that are created for the students to sort of be able to, they can't interact with them, but they can just sort of see what's happening. And again, we've created them and we put them out there for people to use for free. So that's my little pitch on some of the virtual. I have other virtual stuff, but I think that is really the most useful, particularly for low resource settings where you may not have the ability to have like headsets and things like that. So I guess, Jessica, should I turn it back over to you for wrap up?
I think it's about that time. Yeah. Okay. Thank
everybody,
you,
for all
Dr.
your great
Aebersold,
questions.
for, yeah, thank you for facilitating. And thank you to everyone here for participating.